everyone, and welcome to our MASH boot camp. I'm so excited to be here. Thank you for the planners for inviting me this evening. My name is Jordan Mayberry. I am a physician assistant. I work in Dallas, Texas at UT Southwestern, an academic setting in general hepatology. So I manage patients with all liver diseases, kind of right up until we need to evaluate for liver transplant. So being in Texas, of course, we have a lot of MASH. And so we'll talk a little bit today about how we diagnose MASH. So here are my disclosures. I have been practicing in hepatology for about 11 years. So I think it's important for us to remember kind of where we came from. A lot of us know that there has been a new nomenclature that has been accepted for this disease state. But before we referred to this as MASH, there have been a lot of other things that we called it. And so the term NASH was first coined in 1980. NASH was non-alcoholic steatohepatitis. Then in 2002, the AASLD had our first conference on NAFLD, non-alcoholic fatty liver disease. And then it was in 2020 whenever there was a proposal to change the name of this disease state. And at that time, we were considering the name change of metabolic-associated fatty liver disease, or MAFLD. There were a few things that were good about MAFLD and then a few things that we didn't love about MAFLD. What was good is that it recognized the close relationship of the metabolic disorders and steatosis within the liver. But there was a large stigma about keeping that word fatty in the nomenclature. So it was then in June of 2023 that NAFLD was no more and MASH was created. So the AASLD announced that we would no longer be using fatty liver in the nomenclature for this disease state. So when we refer to this disease state, we now refer to it as steatotic liver disease. Steatotic liver disease is a broad spectrum of liver diseases, meaning that there is steatosis within the liver tissue. And that can include a number of things. That is not just MASH or MASLD. Of course, it does include MASLD, metabolic-associated steatohepatitis. But there are several other diseases that this can include. One of the important distinguishing factors for this diagnosis is the difference between MASLD and MET-ALD. That difference is this patient has risk factors for MASLD, but they also have increased alcohol intake. So as we know, when we are evaluating patients that have steatosis within the liver, it's a very important part of our history to document and to determine just how much alcohol these patients are intaking. So there are a couple of different ways for us to determine kind of how much intake there is and then whether or not that is an appropriate level or if that could possibly be affecting the steatosis in the liver. It's really determined by the number of grams. We can determine weekly intake or daily intake, and you see that that's a spectrum of disease. So with MET-ALD, you can have a more metabolic predominant, or you can have a more alcohol predominant. And that's really dependent on the amount of alcohol that this patient drinks on either a weekly or daily basis. Of course, there are patients that have alcoholic liver disease alone. So they do not have metabolic risk factors, but they are drinking alcohol in excess, and that is causing steatosis within the liver. There are other causes of steatosis within the liver. Some common causes are drug injury. So we need to make sure that we are asking about medications. There can be hereditary and congenital diseases as well. And then if we go through that full workup, we do history, we do medications, we rule out any other autoimmune or genetic liver diseases. It could fall into this cryptogenic steatotic liver disease where sometimes we just aren't quite sure what is causing the steatosis within the liver. So the definition of MASLD, that's really why we are here, right? To talk about MASH. or MASLD. And so how do we determine if this patient has MASLD? So what we need to do is we need to make sure that this patient has steatosis in the liver. That is the first step. There's a couple of different ways that we can diagnose steatosis within the liver. Imaging is very common. So I know within our practice, a lot of our referrals are because the patient had an ultrasound, maybe incidentally for something else, or was complaining of right upper quadrant discomfort, and we find steatosis. So either imaging or biopsy. So once we have steatosis within the liver, we need to determine if they meet any metabolic criteria. They must meet 1 out of 5 of these criteria. And it's pretty common for what we would think of MASLD. So elevated BMI, elevated fasting glucose, or type 2 diabetes, if the patient has any changes in their cholesterol panel, and if they have hypertension. So we do need to have at least one of those criteria to fall into that metabolic steatotic liver disease. So if they have one of these criteria, then it's possible that they have MASLD alone, but it's very important as GI and liver providers that we make sure that we're not missing something else, that we aren't getting kind of tunnel vision for MASLD alone. So it's possible that they have more than one liver disease. Did we screen for other possible causes of steatosis within the liver? If they do not meet any of this metabolic criteria, we should still be evaluating these patients for chronic liver disease. They likely came to your clinic because they had steatosis on imaging or maybe had elevated liver enzymes. So we need to be looking for drug injury, autoimmune disease, something of that sort. We know that this is a huge issue across the entire world. We see that the prevalence is high, really all over the world, with the highest being in Latin America, South Asia, Southeast Asia. And the prevalence in North America is about 31%, and then the pooled prevalence around the world is about 30%. So that is a lot of patients that have MASLD. It's thought that somewhere between 60 and 80 million Americans have MASLD. And within that population, within that 60 to 80 million people, 15 to 20 million people are going to be diagnosed with MASH, meaning that there is inflammation within the liver tissue because of that steatosis. Over 3 years, about 20 to 30% of them are going to progress to fibrosis. That means that there is some evidence of damage within their liver tissue. There's about 20% of patients, though, that are considered our fast progressors. And with these fast progressors, they can develop cirrhosis in 10 years. And once a patient has cirrhosis, there is concerns for complications. Of course, liver failure, which can lead to liver transplantation or even death. We know that 30 to 40% of patients with cirrhosis will die of a liver-related complication. Also, once a patient has cirrhosis, they are at higher risk for developing HCC. So with the diagnosis of cirrhosis, we can then see an increased risk about 1.5 to 2% of HCC per year in this patient population. Again, just talking a little bit about how this diagnosis is a progressive disease. You start with normal liver tissue, you have steatosis that is placed into the liver tissue, and that is the diagnosis of MASLD. Over time, that MASLD will then cause inflammation and then can lead to fibrosis. This metabolic risk factors for MASLD is what is causing this to progress from just MASLD to fibrosis. So those include things like obesity, diabetes, metabolic syndrome, and then of course, alcohol use. There are some genetic factors that can also lead to further progression of liver disease. Probably the most common gene that we talk about in liver disease is the PNPLA3. So this is a gene that is known to cause higher prevalence of MASLD, but then also cause these patients to progress more quickly. This is not a commercially available gene, but we do know that this gene is found in higher prevalence in Hispanic patients. So often our Hispanic patients have a higher risk of developing fibrosis and progressing to cirrhosis at much faster rates because of this gene. So let's talk a little bit about a patient. This is kind of a patient that we see really regularly in our general hepatology practice. And I'm pretty sure that all of you guys that are out there treating MASLD see this patient. And even if you aren't treating MASLD specifically, this is probably a patient that you see in your clinic every single day. So this is a 55-year-old man that is referred for elevated liver enzymes. He does report occasional right upper quadrant pain. And he's gained about 20 pounds over the last 5 years. You take a history, kind of talk to him about why he's coming into clinic today. And mostly he's had normal liver enzymes over the last 5 years, but occasionally they've been mildly elevated with an ALT of about 45 and an AST of 50. He has a normal alk phos and a normal total bilirubin. Past medical history includes obesity, prediabetes. His last hemoglobin A1C was 6.3, and he does have hypertension. He has no family history of liver disease, fairly rare alcohol consumption, but he does work in IT, so he has a very sedentary job, is in front of the computer most of the day. He's on lisinopril for his hypertension. And on physical exam, you just see that there's a lot of central adiposity, meaning that, really just carries his weight here in the belly. So what's really important when you have a patient that comes in for a workup of elevated liver enzymes, I talked a little bit about this. We don't want to get tunnel vision. We don't want to look at this patient and say, that's just a MASH patient, wipe our hands of it, and just tell them to lose weight. We want to make sure that there isn't anything else that could be causing steatosis within the liver. So we take a really detailed history. Some common medications for causing steatosis within the liver, you have things like amiodarone, methotrexate, tamoxifen is also very common. And then we want to rule out any other possible causes of liver disease. So making sure that we're looking for viral hepatitis. Wilson's disease is also commonly known to cause steatosis within the liver. So we're going to do a full evaluation. We're going to get that chronic liver disease workup. We're going to look for viral hepatitis. We are going to check a ferritin to look for hereditary hemochromatosis. We're going to look for any autoimmune liver diseases. We're going to check that ceruloplasmin to make sure that we're looking for Wilson's disease, checking HIV, a lipid panel, and hemoglobin A1C. We're also going to get an ultrasound. An ultrasound is a good place to start for evaluating for steatosis within the liver, understanding that it's not a perfect modality. It's good at detecting moderate to severe steatosis, but if the patient has mild steatosis, it may not always pick up the steatosis within the liver. So back to our patient. Overall labs look fairly good. Good news is that platelets look pretty good. INR looks pretty good. So we're not seeing any evidence of portal hypertension, but we do see a little bit of inflammation within the liver with that ALT and AST being elevated at 45 and 50. We got an ultrasound and we see what we expected to see, that there is some evidence of hepatic steatosis, but no evidence of portal hypertension. So when we're talking about diagnosis of MASH, when should we get a liver biopsy? Do we still need liver biopsies in these patients? I know that some of my colleagues will be discussing these non-invasive tests. And I'm sure that a lot of us are using these non-invasive tests for fibrosis measurement in clinics. So do we still need a liver biopsy? And I think that there are a few cases where we may still use the liver biopsy. One of them is to make an accurate diagnosis of MASH. We now have liver-directed therapies for diagnosis of MASH. And so if we are considering starting these therapies, we may want to do a biopsy just to ensure that this patient is a candidate for these therapies. We can also assess prognosis. Another place that a biopsy can be beneficial is if you have discordant information with your non-invasive test. So within our clinic, we do a fibro scan, hopefully at the time of diagnosis, and we do a FIB4. If there is a discordant score for those two tests, we may use a liver biopsy to determine exactly how much fibrosis that patient has. And then also, if the liver enzymes are elevated higher than what you would consider for MASLed or MASH alone, we may need a liver biopsy to rule out any other concomitant liver disease. So if you're concerned that a young woman may have MASH or MASLed and then also have autoimmune disease, a liver biopsy is necessary to rule out any other concomitant liver disease. So when we're talking about the diagnosis of MASH, I think that there are some important questions that we have to ask ourselves. First, the primary question is, does this patient have steatohepatitis? Because in order for this diagnosis to be made, there must be steatosis within the liver. That is the first thing that we need to make sure is present. So if they have steatosis in the liver, is this related to MASH or could it be related to something else? We need to rule out other causes of steatosis. And then the second question would be, does this patient have any fibrosis? And if they do have fibrosis, do they have stage 3 or 4? So do they have advanced fibrosis? Because if the patient does have advanced fibrosis, then we may treat them a little bit differently. So that's a little bit about the diagnosis of MASH. And so we're going to move on to the NITs. Yes. So we'll talk a little bit about that next.